Now I call upon our President, Dr. Priya Karthik Prabhu, for the welcome address.
Good evening, everyone. Respected Chairman of AMS of Tamil Nadu State, Dr. Rajesh Babu, AMS Chairman of Coimbatore Branch, Dr. Balamuthan, Secretary of AMS Wing, Dr. Jalil Ahmed, our Course Director, Dr. Vikram, and our esteemed faculty for the day, Dr. Professor Pazhani Ranganthan and Dr. Ragahavendan, colleagues and all dear students. So Coimbatore IMA is very happy to be associated with the neurology course for the benefit of PGs. And since many postgraduates are there, I would like to tell a few words about IMA. So Indian Medical Association is the largest association for doctors, and those of you who have not yet become members, kindly become members. IMA is the body which fights for the rights of the doctors, and we have many schemes to protect yourself. We have the professional protection scheme, and for the family members, we have family security scheme. And in case you haven't decided where you're going to settle down, you don't know which branch to choose from, there is an option of becoming a member of the Junior Doctors Network up till the age of 35 years. And then you can become a life member in whichever branch you settle down. So once again, we are happy to be associated in this forum, and I welcome you all. Thank you.
Thank you, Dr. Priya. Now I call upon our State AMA AMS President, Dr. Rajesh Babu sir, also being the course director of the program, who is responsible for the program today, to address the meeting, please.
Good evening, everyone. I thank the President of IMA Coimbatore, Dr. Priya Karthik Prabhu, for joining forum with our neurosciences forum. Every month we are planning to conduct one CME for the PG's benefit of the PG students. In that, we will be having one neurology topic and one neurosurgery topic. And this month being the World Organ Donation Day program was there, we were thinking about conducting a brain death, the neurologist view and the neurosurgeon's view. That's why we have done it. And I welcome you all for this nice program. And at the end of the program, the questions will be asked and the PGs can answer and get the prizes from it. So I welcome you all for this nice session. Thank you for the opportunity. Over to Balamurgan, sir.
Thank you, sir. And probably now, can you move to the
at this juncture, I like to invite our Dr. Suresh Jayabalan, the president of our Tamil Nadu Association of the Neurosurgeons, who has also joined the program. And today we have a nice speakers, Professor Pazhani sir, who is a neurophysician with law also he has done, and he is going to give a wide view about it. And Dr. Ragahavendan sir, the professor of the professor and HOD of MMC, who is going to talk about the neurosurgeon's view. Over to Dr. Balamurgan sir.
Yeah, thank you, Chairman Dr. Rajesh Babu sir, and the course director of the program. And probably we can go directly to the scientific program. Start with the first speaker, which has already been introduced, and just a brief introduction again about Professor Dr. Pazhani Ranganthan, DM Neuro, MRCP UK and FRCP London, Senior Consultant Neurologist, Professor Emeritus, the Tamil Nadu Doctor Input, and he is Emeritus Regional Advisor, Royal College of Physicians of Edinburgh, Tamil Nadu. And yeah, this is about, and he's got, he has been a chair, vice chair of many programs, and vice chair of General Neurology, American Academy of Neurology, founder president of South India Neurological, European Board of Neurology, fellow European Academy of Neurology, and fellow of American Academy of Neurology, fellow of American Neurologists Association, and he has done LLB and ML, Intellectual Property Rights, and PG Diploma in Medical Legal Aspects, Diploma in Music, and Diploma in Astrology. And more than very important, I'm very happy to be there today's meeting because Pazhani is my classmate in MBBS, Madras Medical College. And I'm very happy. And he's very, from his college days, Pazhani is always very serious in studies and used to always, very calm and quiet. And today he's not only in the medical, he has got other avenues also. A lot of other areas of. Welcome Professor Pazhani Ranganthan to give his talk on brain death, neurologist perspective, please. Over to Dr. Pazhani.
Thank you very much. Thank you the Academy and the Indian Medical Association for the opportunity to give a talk on brain death from neurologist perspective. About brain death from neurologist perspective, because followed by Professor Ragahavendan will be speaking on from neurosurgeon's perspective. And so I just stick on to the neurologist perspective. So brain death, both a legal and clinical term, and has been present in medical literature and text for many years, and was defined by the brain death, both a legal and clinical term, has been present in medical literature and text for many years, and was defined by the Uniform Determination of Death Act in 1981. It's a very important act, and you can go through the detail in Google. You can get this entire detail about it. I will be covering that also in the coming slides. This course is designed to equip healthcare professionals with a deep understanding of multifaceted aspects of brain death, from its pathophysiology to its ethical and legal ramifications. It is primarily focused on three core areas: the etiology and progression to death, brain death, distinguishing brain death from other states such as coma or vegetative state, and comprehensive criteria and protocols for the diagnosis of brain death. It's very, very important. Actually, in the emergency setup as well as in on-call setup, we'll be asked to see these patients to give an opinion about the brain death, especially in neuroscience. So a lot of things are changing, especially the American Academy of Neurology 2023 criteria, which I'll be covering later. So latest standards and practices in diagnosing brain death, emphasizing clinical assessment, that is brainstem reflex testing, and the uses of ancillary test, aims to enhance the competence of healthcare professionals across disciplines, fostering an interprofessional approach to managing this challenging aspect of patient care. Maybe in a city or maybe there are a lot of multi-specialty hospitals, getting a specialist is not a difficult issue. But as we go to the district level, and especially some of the many districts now have, but some of the district and some of the more peripheral areas, it is very, very important to create an awareness about brain death and the criteria. It is important to equip the healthcare team with the necessary knowledge and skills to effectively navigate brain death clinical, ethical, and legal complexities, ensuring high quality, compassionate care for patients and their families. This is not very simple like other clinical diagnoses, and we can make a diagnosis and give some treatment and go away from the place. It is a lot of sensitive area, and a lot of communication need to happen, and they need more of a multidisciplinary teamwork and communication. So it is not a very simple issue to deal with as an individual. So we have to identify the etiology of brain death, interpret the physical examination of a patient with a potential diagnosis of brain death, apply the appropriate evaluations to a patient with potential diagnosis of brain death, communicate the importance of improving care coordination among interprofessional team members to ensure appropriate utilization of the legal and clinical definitions of brain death are met. So it is we have to follow all the protocol. We should not miss even a single thing, because I'll cover in the future that what is the chance of error that if we don't cover the proper protocol in declaring brain death. Death is defined in the United States by the Uniform Determination of Death Act, UDA, proposed in 1981. A determination of death must be made in accordance with the accepted medical standards and must additionally include one of the following: that is, irreversible cessation of circulatory and pulmonary functions, irreversible cessation of all functions of the entire brain, including the brainstem, is dead. This is the definition of Uniform Determination of Death Act. This is different from our brain death criteria. But brain death criteria follows most of the recommendations of UDA. That is the first thing which is made. The UDA was drafted in the late 1970 in response to medical advances in life support that allowed for complete circulatory and respiratory support despite complete cessation of brain function. Because when the technical advance happened, a lot of the intensive care facilities available, people are able to support artificially the circulatory and the respiratory system. Then everything has evolved over a period of time. The UDA did not establish what accepted medical standards were, instead, only that they existed. The American Academy of Neurology published the initial standards in 1995 and updated them in 2010 to the current standards. American Academy of Neurology recent position statement on brain death endorses UDA's death definition as this is the UDA's death definition as per AAN. Irreversible cessation of all functions of the entire brain, including the brainstem, has been determined by the demonstration of complete loss of consciousness, brainstem reflexes, and the independent capacity for the ventilatory drive in the absence of any factors that imply possible reversibility. It's very important to make sure we are not missing any reversible factors. Irreversibility in the definition of death refers to the impossibility of recovery, regardless of any medical intervention, which requires clear elaboration as with the advancement of mechanical ventilation and life support technologies during the 20th century. Patients who suffered severe brain damage could be maintained physiologically for prolonged periods in intensive care units. There are a lot of papers, there are a few papers available about how long you can maintain when the brain is not functioning with artificial means. I think some of the maximum up to 28 days they can maintain. So after that, in spite of all supportive measures, everything collapses. So it's from 1 week to 28 days. There are some papers available on long-term follow-up of these patients. American Academy of Neurology, in addition, believes preserved neuroendocrine function may be present despite irreversible injury of the cerebral hemispheres and the brainstem, and is not inconsistent with the whole brain standard of death. So they can have sometimes a preserved neuroendocrine function even though they are brain dead, and especially you have to be careful about some other spinal reflex. These are things which can be preserved in spite the patient is brain dead. In 2012, the World Health Organization partnered with an international forum to endorse brain death as the official diagnosis of death. Internationally and even within different states of the United States, there is no uniformity to certify brain death. Brain death criteria also differ based on the patient's age. Therefore, different standards are in effect when performing document of brain death, and the provider should be aware of their country, state's criteria for a specific patient age. It's very, very important. Within the United States, a different state has some difference in the criteria, and we should be very careful in the age also. For below 37 weeks, we have to be very careful because the brainstem reflexes are not well developed in this before 37 weeks. So then you have to be careful about children and pregnant women, which I will cover in the coming slides. So we have to look into all the factors, the age and gender, and all those factors, different state, and what is the law in different parts of the world actually. So what we are following is the law of the land. So there is a law of the land for everywhere. Even though there is a generalized criteria, there are some differences there. Distinguish the term brain death from coma to the public is essential, as coma may imply a limited form of life. So the patient may ask that is he in coma, is he dead? So they may not understand all these technical terms. So it's very, very important that sometimes we may be tired while explaining. We may not be able to explain that what we really want to explain. So we need a lot of team work and team discussion to explain to the public that what we are dealing with for them to understand. The understanding that brain death is equal to death helps guide decision making for both physicians and patient families regarding the withdrawal of care, and prevents unnecessary expenditure of resources. So suppose there is nothing is there, the brain is not functioning, and we may be continuing all the life supporting measures. The patient may ask that what's happening. So we can tell that we have to start initiating the discussion when we know that there is brain death happening or happened. Then we have to explain to them that how things are going to be. An essential topic that evolved in parallel with brain death is obtaining organs for transplantation. This is the important the clinical as well as legal role happens, and because most of these definitions are very important for the transplantation purpose. According to the dead donor rule, there's something called dead donor rule. Organ procurement can occur only after death has been declared. Therefore, for patients who are brain dead, the procurement of vital organs is allowed, even if a patient still has some circulatory and pulmonary function. Because of the technology and intensive care, we are able to maintain the circulation and pulmonary function. The brain dead, that's very important, the brainstem death criteria and all those things, especially when we are going to deal with organ donation. Differentiating brain death from other forms of severe brain damage, including vegetative state and minimally responsive state, is very, very important. So we know that there's something called persistent vegetative state and minimally responsive state. They are not brainstem death or brain dead patients, and it's very important to differentiate this group of patients from that. In a vegetative state and minimally responsive state, some brain functions are maintained, resulting in a chance of recovery, even occasionally after prolonged periods, especially in patients with a traumatic brain injury. So if there is some response is there is brain functions are maintained, we have to be very careful, and because it's definite criteria for brain dead or brainstem death patients. Brain death occurs as a result of an acute catastrophic brain injury. Abrupt loss of cerebral perfusion occurs if a concomitant elevation of intracranial pressure exceeds the mean arterial pressure. The formula is as follows. So cerebral perfusion pressure is equivalent to mean arterial pressure minus intracranial pressure. This process was studied by monitoring brain tissue oxygenation in patients with brain death and can occur via two different mechanisms. Intracranial causes. In adults, the predominant intracranial injuries leading to brain death are traumatic brain injuries, subarachnoid hemorrhage. These injuries elevate the intracranial pressure, impair the cerebral perfusion, and reduce brain tissue oxygenation, leading to neuronal damage. In pediatric cases, non-accidental trauma is a common cause, contributing to increased intracranial pressure and subsequent brain injury. The extracranial causes are in both adults and children. A significant extracranial cause of brain death is cardiopulmonary arrest with a delayed or inadequate resuscitation. This leads to prolonged cessation of cerebral blood flow, resulting in anoxia, cellular membrane pump failure, disturbed osmoregulation, and severe brain edema. The increased intracranial pressure within the confined space of the skull further compromises the cerebral perfusion, exacerbating the neuronal injury. So higher the pressure, more the neuron get damaged. The most common process leading to brain death in order of frequency are cardiopulmonary arrest, traumatic brain injury, subarachnoid hemorrhage, and intracerebral hemorrhage. I think in cardiopulmonary arrest, the common scenario of the neurologists we are involved. In traumatic brain injury, subarachnoid hemorrhage, and intracerebral hemorrhage, the neurosurgeons are commonly involved. Even though we have been asked to give opinion, especially hypertensive subarachnoid hemorrhage, or always a neurologist get involved for neurological reasons in some of these patients. But commonly we have been called for after cardiopulmonary arrest. Among the extracranial causes, patients who experience cardiopulmonary arrest show progression to brain death in 8.9% of cases of post-resuscitation. Very important. So these patients, up to 8.9% of patients can go for a brain death situation after the cardiopulmonary arrest. For those presenting with a traumatic brain injury, the rate of progression to brain death ranges from 2.8 to 6.1%. Recording the intracranial etiologies, patients with subarachnoid hemorrhage progress to brain death in 8.5 to 10.7% of cases, while those with intracerebral hemorrhage progress at the rate of 6.1 to 9.6%. By definition, brain death is associated with a 100% mortality rate. So if there is a brain death, brainstem death, there is 100% mortality rate. So it's very, very important before putting the stamp on the diagnosis that we make sure that everything is properly protocol followed and there is no violation happens. So overall, in all the cases, you can see up to 10% of these patients go for a brain death situation. If you take the pathophysiology, the physiology of brain death is similar regardless of the etiology. Inadequate, so whatever the cause, the ultimate the consequence, pathophysiological sequence is same. Inadequate tissue oxygenation leads to a progressive cascade of further edema, increasing intracranial pressure, further decrease in the cerebral perfusion, and eventual herniation or complete cessation of blood flow and aseptic necrosis of the brain tissue. In anoxic brain injuries, inadequate cardiopulmonary resuscitation following a cardiopulmonary arrest, tissue hypoxia leads to release of cytotoxic material that leads to progressive cerebral edema and eventually the cascade described above. For traumatic brain injury or other intracranial injuries, increasing intracranial pressure leads to a decrease in the cerebral perfusion pressure and prevents adequate oxygenation of the neuronal tissue. This situation will result in further injury, edema, and eventually the process initially as above. So ultimately, you can see whatever the etiology, the ultimate cascade is same. So if you take the histopathology, the microscopic evaluation of postmortem brain dead patients reveals varying degrees of neuronal ischemic changes. The hemispheric lobes and basal ganglia are the most common areas to experience severe ischemic change. So you can see even after the post-arrest patient that if you take an MRI, you can see shadows in this area. And suppose if you see extensive shadow in the hemisphere and the basal ganglia, it is not a good prognostic case. Followed by the pons, medulla, midbrain, and thalamus. So the brainstem area, hemispheric area, basal ganglia shadows are not a good prognostic sign. Autolysis of the cerebellum can also be appreciated in many autopsies. So people have found in autopsy patients that there is autolysis of the cerebellum in a brain dead situation. The history and physical examination. The beauty of clinical neurology, neurosurgical, neuroscience as such, not only neurology, neurosurgery, is still it is clinical medicine. People cannot eliminate the clinical medicine from neuroscience. Brain death determination to conclude. These three conditions must be present. One is coma. Second thing, absence of brainstem reflexes. And third thing is apnea. So very important, look for a state of irreversible state of unconsciousness, absence of brainstem reflexes, and apnea. Coma should be evaluated by ensuring lack of responsiveness to noxious stimuli, no eye or motor reflex. We look for the oculocephalic reflex and all those things, and no spontaneous eye movements. Motor reflex should be present in response to stimuli. So when you stimulate, you don't see all these things. Spinal mediated reflex movements, including muscle stretch reflexes, may be compatible with brain dead. Sometimes you see these spinal movements, which can happen even in brain dead situation. The cause of the coma should be identified by neuroimaging, history, physical examination, or laboratory testing. Laboratory tests like we do the ABG, then we do the metabolic screening, and the physical examination. We discuss three important things like coma, absence of brainstem reflexes, and apnea. History is what happened to the patient. And neuroimaging, as I was telling, that extensive shadow in the hemisphere, basal ganglia, and brainstem. The following cranial and brainstem reflexes should be tested in the physical examination of a patient eligible for brain death evaluation. They all must be absent for a patient to be diagnosed as brain dead. So cranial 2 and 3, people should be fixed, mid-sized to dilated, and not reactive to light. A magnifying glass or pupillometer can be used to evaluate further if the results are equivocal. I have seen people using a magnifying glass to see whether people are still reacting a little bit. Sometimes in our physical eye can miss certain things, so that people use sometimes magnifying glass or a pupillometer. Cranial 3, 6, and 8, the oculovestibular reflex can be tested using the oculocephalic reflex or caloric testing. When the oculocephalic reflex is absent, the eyes will turn the same direction in which the head is turning. Testing for the oculocephalic reflex should only be performed in a patient with a stable cervical spine. Suppose we are in the process of evaluation, patient had a very bad cervical spine injury, and we should be very, very careful in testing. We should not precipitate acute cardiac arrest, especially when the patient is going to survive. We are only suspecting it. Cold caloric testing may be performed by irrigation of 1 ear with 50 to 60 ml of ice water. An absent oculovestibular reflex is indicated by lack of movement of the eye towards the irrigated side within 1 minute. The contralateral ear should be tested after 5 minutes. We should not do the test the next ear immediately. We should wait for 5 minutes, then we should test the other ear. So it's very important. Every procedure has a way of doing it. We should not do it in a way because our work is very busy. Will be running from here and there. And I think the neurologists are more busier than us, especially when they have more emergency on admission day. And it is better as a teamwork, and we train people to do this, and the team can have this time to wait for 5 minutes and do the other side. Cranial 5 and 7, loss of corneal reflex is determined by using a cotton swab, drops of water or normal saline. Even if you put 1 drop of water, normal saline, that also is a kind of a corneal reflex only. So loss of gag reflex, cranial 9, loss of gag reflex is confirmed after stimulation of bilateral posterior pharyngeal membranes without elevation of the palate. So we have to be very careful, and The gag reflex has a way to do it actually. It should be visible and it should be done very quietly without disturbing the posterior area of the mouth. And otherwise, when you are pressing that, it may be artificial kind of movement. So loss of cough reflex, cranial nerve 10, is confirmed after tracheal suctioning without reaction. While suctioning, you can see there is no cough reflex at all. Before deciding to proceed with the diagnosis of brain death, several conditions must be evaluated and met. Evidence of an etiology of coma should be known. Medical conditions should be excluded, including metabolic, severe metabolic, endocrinological, and acid-base derangement. If a drug intoxication is suspected or if recent neuromuscular blocking agent have been administered, then 5 half-lives of drug clearance should be weighted with adjustment to renal and hepatic function. If you should know the renal function status, hepatic function status, then what drug is used for this patient, then we should wait for the 5 half-lives of drug clearance time before thinking that the patient is brain dead, because you can get a spurious information prematurely doing that. The core temperature must be 36 degrees, above 36 degrees centigrade. Systolic blood pressure more than 100 millimeter of mercury. Vasopressor may be administered if necessary. Neurological examination, especially brainstem reflexes in most states in the United States, one attending physician examination is sufficient. However, some states require 2 physicians. That's what I was telling, that every state has some marginal difference in the criteria. Some states say, okay, 1 is enough, and some states say we need 2 people to conquer. If the above conditions are present and there is an identified cause of coma and complete lack of brainstem reflex, may proceed with apnea testing. Apnea testing should be reserved for last and only once a diagnosis of brain death is reasonably determined, since elevating partial pressure carbon dioxide in the arterial blood increases intracranial pressure and could precipitate a cerebral herniation. So we should very, very thoroughly test all the other things, make sure that there is nothing like brainstem reflexes and everything we have avoided. And this we are going to do as a final test. We should make sure that everything is satisfied before going for the apnea testing. Apnea testing is performed using the following procedure as recommended by the American Academy of Neurology. Vasopressor should be adjusted to maintain a systolic blood pressure of more than 100 millimeter of mercury, and pre-oxygenation is given for at least 10 minutes with a 100% of FiO2 to a PaO2 more than 200 millimeters. It's very important to stick on this protocol in the intensive care so that we don't need to remember everything. Reduce ventilator frequency to 10 breaths per minute. Reduce positive end expiratory pressure to 5 centimeter of water. If SpO2 remains more than 95%, obtain baseline blood gas. Disconnect the patient from the ventilator and preserve oxygenation with the oxygen delivered through insufflation tubing given at 100% FiO2 at 6 liters per minute near the level of carina through the endotracheal tube. Look for respiratory movements for 8 to 10 minutes. See, it's time-consuming process. Make sure that you spend at least 10 minutes to make sure that there is no respiratory movement. Repeat blood gas at approximately 8 minutes if no respiratory drive is observed. If no respiratory movements are observed and PaCO2 more than 60 millimeter or 20 millimeter of increase in PaCO2 over baseline while doing that, the apnea test result is positive. If the above list is completed and the absence of brainstem reflexes and a positive apnea test are present, the diagnosis of brain death can be made. This procedure is validated and supported by several professional organizations. The apnea test has to be aborted if any respiratory movement exists. Systolic blood pressure decreases to 90 millimeter. Oxygen saturation is less than 85% for more than 30 seconds. If so, the procedure has to be retrieved to the TPs, maintaining a continuous positive airway pressure of 10 centimeter of water and administration of 100% oxygen at 12 liters per minute. Although not required for the diagnosis of brain death, hospitals frequently have additional ancillary tests available to confirm the diagnosis of brain death, which is not mandatory. Keep in mind, doing all these tests will make everything more complicated, and people do sometimes if they are not very sure about it. Ancillary tests are used when apnea testing is inconclusive or patients are too unstable to proceed with apnea testing. These tests include cerebral angiography. 4-vessel angiography is the gold standard for cerebral blood flow evaluation. Angiography can confirm brain death when it shows a cessation of blood flow to the brain. Cerebral angiography limitations include the test invasiveness and transferring the patient to radiologist suite Also, the contrast may induce nephrotoxicity affecting the donor kidney. If you are planning for a renal transplant, the organ donor patient, and when you are doing cerebral angiography, we have to be very careful that we should not produce any dye-induced nephrotoxicity. False negative tests can occur when intracranial pressure becomes lowered by surgery, trauma, or ventricular shunt. If the patient had a procedure, a neurosurgical procedure, or patient had extensive trauma, when the pressure is ICP is very low, and then it can give spurious result. Transcranial ultrasound can be used to assess bilateral pulsations of the middle cerebral, vertebral, basilar, anterior cerebral, or ophthalmic arteries. The transcranial ultrasound can confirm brain death by showing small peaked systolic pulsations or the absence of diastolic pulsations. Test limitation include the examiner's expertise, unsuitable windows due to thick temporal bones, and lowered intracranial pressure by surgery or ventricular shunt giving false negative tests. So we need expertise in doing this test. Suppose people don't know how it look like in brain dead patients, it's better not to use this tool as an additional measure. Computer tomography and magnetic resonance angiography of the brain may be used to show cessation of cerebral blood flow. Radionuclide brain imaging. This can be done using a 19 technetium labeled hexamethylpropylene amine oxime, that is HMPAO isotope tracer, and then imaging by single photon emission computer tomography, brain scintigraphy. The absence of a tracer in the cerebral circulation, it is called as hollow skull phenomenon, is consistent with the brain death. The test may show false positive results if the imaging is done in one place only instead of two planes. Very important to make the picture in two planes. We have to ask the radiologist, is it taken in the two planes, or we have to tell them before doing the test, we need a two-plane picture. Somatosensory evoked potentials. Patients with brain death show no somatosensory evoked potentials in response to bilateral median of stimulation and no brainstem auditory evoked potential in response to auditory stimuli. SSCP can confirm EEG finding as it is less affected by drug intoxication, however, they can still be affected by hypothermia. So when the patient is on toxin and too much of sedation, a lot of things can affect EEG finding, even though EEG is not taken as a criteria, but SSCP is not affected by all these factors, so it can be absent. It is absent in brain dead patients. So once brain death has been diagnosed, the patient is clinically and legally declared deceased at the time of completion of brain death testing. At this time, depending on family and patient preference, cardiopulmonary support should be withdrawn or arrangement for organ harvest should commence. Adequate documentation of all criteria of the diagnosis of brain death must be included in patient medical record. It's very, very important. Documentation is very important to avoid any legal issues in the future. We should spend adequate time in documenting everything in the notes. It is recommended that some form of checklist should be used to ensure that completeness of brain death testing. It may be better before a checklist paper which should be attached to this patient case note, and so that we don't miss anything. Several conditions mimic brain death, including those listed below. Like as I was telling, vegetative state, minimally responsive state, locked-in syndrome. I had two locked-in syndrome patient in practice. Some few years back, one patient had a GBS with brainstem demyelination. Only patient can do vertical eye movement. Another patient had a brainstem demyelination followed by chicken pox. And both of them recovered and walked back home. It's very important to look for sometimes vertical eye movement. This patient had only vertical eye movement, with a total like brain dead patients. But other findings, we not gone for that extent. We clinically picked it up. Hypothermia, drug intoxication, Guillain-Barré syndrome, and delayed paralytic clearance, like neuromuscular paralytic agents. The clinician should perform a clinical evaluation to exclude these conditions before proceeding the brain death examination. It is essential to differentiate between coma and brain death, and the American Academy of Neurology guidelines are followed. There have been no misdiagnosis of brain death reported in the literature, or the reported misdiagnosis, at least one violation of the AN guidelines was identified. So we should not violate any, we should not bypass, or we should not skip some procedure, so that can lead to misdiagnosis. The diagnosis of brain death is difficult for families to accept. Research support asking family to witness the clinical evaluation of brain death will help them understand the diagnosis. This is the Western literature statement, and how it is feasible in our setup while doing all this procedure in front of the family is a very difficult situation, I think, but we need a lot of multidisciplinary team to examine to explain to the family. Multiple meetings with more than one provider. Clergy is the person, spiritual person, and whatever religion they follow. This is a Western standard. And the social workers or ancillary staff may be necessary for the family acceptance of the diagnosis. The designation brain death involves an interprofessional team. As I was telling, very difficult for a single clinician to hold all the responsibility on his head. Nurses, physicians, social workers, clergy will play a vital role in coordinating with families during the process of brain death examination and counseling after the diagnosis has been made. Subspecialists such as intensivists, neurologists, neurosurgeons are required to interpret the physical examination of findings, and radiologists may be necessary to interpret ancillary testing, the clinical diagnosis inconclusive. Whilst the diagnosis is considered, an interprofessional team, especially trained in organ procurement, should be involved. This specialty team should handle all the aspects of care only once a diagnosis of brain death has officially been made to ensure adequate protection for the team that cared for the patient until the diagnosis of brain death. Adhering to the guidelines of clinical evaluation, ethical considerations, legal responsibilities, interprofessional collaboration, effective communication, healthcare professionals can provide comprehensive and compassionate care in managing brain death scenarios. This approach ensures that patients and their families receive the highest standard of care, significantly improves the outcomes and strengthens team performance in this complex and sensitive area, very sensitive area of medical practice. I just finished another 1 or 2 slides. The Transplantation of Human Organs Act. I think everybody should read that, especially more important. But anyone practice intensive care, critical care medicine, and physician, they also involved because some of their patients like go for cardiologist. They see that's a common scenario. Even though that the other team is involved in helping them, it is basically everyone should be involved in declaring and evaluating the situation. It is the Transplantation of Human Organ Act, that is THOA 1994, was enacted in year 94. Main purpose of the act is to regulate the removal, storage, and transplantation of human organs for therapeutic purposes and for the prevention of commercial dealings in human organs. The act was amended in 2011 and the Transplantation of Human Organs Act 2011, that's Amendment Act. The amended act is now named as Transplantation of Human Organs and Tissue Act, that is TOTA 1994, but the amendment happened in 2011. Brainstem death is recognized as legal death in India under the Transplantation of Human Organ Tissue Act since 1994, like many other countries, which has revolutionized the concept of organ donation after death. After natural cardiac death, only few organs, tissues can be donated, like cornea, bones, skin, and blood vessels. Whereas after brainstem death criteria, almost 37 different organs and tissues can be donated, including vital organs like kidney, heart, liver, and lungs. The important amendments in 2011 are tissues have been included along with the organs. Near relative definition has been expanded to grandchildren, grandparent. Provision of retrieval center is explained. Provision of swab donation is included. Provision of mandatory inquiry from the attendance of potential donors, the admitted in ICU. All these things, the act is there. You can go and read elaborately. It's quite. It's around 8 to 9, 10 papers. The proper act you can see in the internet is available. Provision of mandatory transplantation coordinator, transplant coordinator. To protect vulnerable and poor, there is a provision of higher penalties has been made for trading in organs. Constitution of brain certification board has been simplified, and the National Human Organs and Tissue Removal and Storage Network is formed. It's called the NATO. Then State Organs and Tissue Removal Storage Network is called SATO. There is provision of advisory committee and the retrieval of cornea. Who else can do that? Act has made provision of a greater caution in case of minors, foreign nationals, and prohibition of organ donation from mentally challenged persons. So thank you very much. And the main topic is I just covered as a neurologically what is brain death, and basically it's a brainstem death for organ retrieval purposes or declaration purposes. What are the criteria followed? And the American Academy of Neurology 2023, please read the guidelines. It is in the net actually. The two important things they included is one is declaring on ECMO patients. They are declaring in pediatric population, which I don't want to cover, but the next speaker need a lot of time to, because a lot of things we need to hear from him. And third thing is in pregnant women. Suppose a pregnant woman go and the same criteria can be applied, and there is no contraindication. Only thing, if they have live fetus, it need a multidisciplinary approach. The fetus is alive, and what to do, all those things are there in the latest American Academy of Neurology. Brain is called brain dead, and the criteria. There's a lot of organization involved, like American Academy of Neurology, Critical Care Medicine, and the Pediatric Society, And that is there in the website to go through extensively. It's a very good paper, statement on brain death AN 2023 criteria. Thank you very much.
Thank you, Dr. Pazhani, for a wonderful, elaborate presentation on brain death. We came to learn about brain death for almost 30 minutes about brain death and so many criteria. Sir, probably can we take up the questions at the end of the presentation, Pazhani?
That will be better.
Yeah,
Okay.
end of the presentation we'll take, and probably we'll move on to the next speaker, Dr. R. Ragahavendan, MCH, Neurosurgery, Director and Professor, Institute of Neurosurgery, Madras Medical College, Chennai, and here the opportunity of getting the Professor S. Kalyan Raman Gold Medal for Best Outgoing Student, Best Doctor Award in Government of Tamil Nadu, and COVID Management Excellence, Medical Excellence Award. Is contributed to the South Asian edition of the textbooks, many textbooks, as well as is Senate member of Super Specialty Board of Studies of the MGR Medical University, member Brain Death Committee, TANSTAN, Secretary Chennai Neuro Association, and founding the EC member TANS. And overall, looking at his profile, looks very impressive, Dr. Ragahavendan. And we are happy to have you here today to give you a perspective, the neurosurgeon's perspective of brain death. Over to you, sir.
Good evening, everyone. And it is indeed my privilege. It is a pleasure and privilege to be present here in this meeting with all of you. And I sincerely thank most respected Dr. Rajesh Babu, the course director, the AMS of IMA, and the course director, Dr. Vikram Subramanian, and Sir Balamurgan sir, and Dr. Priya Karthik Prabhu, the chairman. And because I am also an alumni of MMC like Suresh Jayabalan and Palni sir. In fact, Palni sir was doing his MD General Medicine when we were in CRR period. I still remember those periods. And Suresh also will be familiar with that. He was an immediate senior to me. He was the president of TANS. So at the outset, I immensely thank IIF for inviting me to give this talk on brain death, which has been a passion for me for almost 15 years now. Right from the time 2008, we all sat together and formulated the initial GO number 75 unto its present day one. So there are certain disclaimers which I would like to propose here. This is just a scientific presentation, and I do not intend to change anyone's concept about death or brain death. Number one. Number two, as part of the Brainstem death guidelines by the TransTan, I'm a member of the committee. I'm head of the 3-member committee. We have proposed the guidelines and we have revised it in 2023 April, and it is available in the TransTan website. And that is exactly what we follow today as per the Government of India guidelines in our state to identify and declare somebody as brain dead. I will restrict myself to these guidelines only. I will not go outside. And I can assure you one thing. I'm presenting this based on purely on experience, and till date, I have the highest number of brainstem death certifications in the whole state, and if not the whole country. And as you all know, every year RGGGH or Madras Medical College stands first. Last year we had 26 when AIMS Delhi had 13 and PGH Chandigarh had 13. They came joined second place. This year we have already marched on to 27. We still have one brain death. So what all I share with you today is purely about practically how we identify, diagnose, certify brainstem death, and it will be within the guidelines that has to be followed when we are within the state of Tamil Nadu. I will restrict that to myself to that aspects only. I will not go outside of this. And for further reading, I request you to verify with the, go through the TransTan website, which has all these guidelines. To start with the blessings of Almighty, We neurosurgeons, we are fond of Lord Ganesh because we think he is our first patient. And the first neurosurgeon being Lord Shiva, who did a head transplantation. But today's topic has a lot of relevance to this mythology behind this Lord Ganesh image of an elephant head and a human body, because we all have transplanted everything from head to toe. As Professor Palni sir has mentioned, 37 organs. We have transplanted hair, cornea, heart, lung, liver, kidney, skin, intestine, bone, everything. But as human beings, are we capable of doing this particular procedure of a brain transplant or a head transplant on another human being successfully? It is not. We will never be able to do it. How many centuries also? This thing, one thing is not beyond human beings. Only God is capable of doing such mythological things. That is how I start my talk today. This is where I studied, as we all, this is my alumnus. I studied in the Madras Institute of Neurology. So before we start, light is the source of life. As is always, right from the microorganism to the human beings, light has been the source of life. And the sun, we all know, is an eternal source of life. But a human body cannot be equated to an eternal source. It is like a candle. It burns down. It gets extinguished itself. The duration, how long the flame burns, may differ based on the height or the thickness of the candle, but ultimately it gets extinguished. But we are physicians. We are trained to sustain life. And our motto is to make this flame glow eternally. Isn't that? That is what we are trained for. And how to do it. That is exactly what we'll see learn. So before going into the concept of brain death, I'll have a brief while play with the concepts of death. The concept one is, right from the day an animal was born, the animal had died. Right from the day the first human being was born in the earth, he had died. So how was death diagnosed? If you look at anecdotal references and cave paintings and other carvings, see, there was a criteria. When somebody refused to open their eyes, cannot open their eyes, they were considered as dead. When all body movements stopped except breathing, they were considered as more dead. And when breathing stopped, they were considered as completely dead. Across continents, across tribes, without any communication between them, this has been a basic concept how death was diagnosed. So, cessation of respiration was the defining moment between life and death. In the 1800s, there was a paradigm shift. Namely, there was one invention. Lennox invented the stethoscope, and Sir William Harvey discovered cardiac circulation. And we are well told that cardiac circulation is essential to maintain life, and the presence or absence of cardiac circulation can be heard with a stethoscope, and the absence of cardiac sounds means death. So we had a paradigm shift. We shifted from respiration to heart sounds, hearing of heart sounds. We were fascinated. So how long did it last? Probably 100 years. We'll see. The other concept, second concept, was visible death. We all know before 1940s, death happened at home. The relatives would have gathered. The neighborhood will know that there is a terminally ill person. Death is imminent in a family. Sometimes the sick are anointed. The priests have gathered. And on many occasions, death was facilitated also by pouring something into the mouth to drink or like that. But there is no doubt, but death is limited. There's no doubt in diagnosing a death at all. After the 1940s, medicine as a science advanced at a rapid pace, very rapid pace, and it resulted in patients being shifted to ICU. Today, almost 90% of the death happens in an ICU within a hospital. Patient might have been admitted for a common cold. A code blue is developed. Patient goes into the ICU, intubated, put on ventilator, on life support measures. What is going to happen? Irreversible brain damage has already been happened. So this concept of death that happens away from the family members, away from everyone else, where only the physician is present, is the concept of invisible death. And that is where we are today. If you look at brain death, it is discovered but not invented. For the first time in the 1940s, when poliomyelitis was rampant and patients were dying because of respiratory failure, because of this, the Danish medical students found a way to do a tracheostomy, put in a tube inside, and somehow managed to sustain life, sustain respiration, and some of them recovered. And cerebral circulatory arrest is demonstrated in comatose patients. Actually, it was Egas Moniz, a Portuguese neurologist, who invented the cerebral angiography in the early 1950s. And in the same time, mouth-to-mouth resuscitation gained prominence, mechanical ventilation became a possibility. And in 1954, we did our first successful renal transplant between identical twins, and it was a success. And in 1959, based on all these aspects, the French physicians identified or proposed something called coma la dépasse, which in other words means brainstem death. Because of this improved ICU care, all these comatose patients in irreversible coma, they were being maintained endlessly on a ventilator. They were in deep irreversible coma. They could not breathe. Brainstem reflexes were absent. Most of them had diabetes insipidus, cardiovascular instability. They were poikilothermic, and inevitably followed by asystole. But Mullaret and Golan made one very important observation, because cerebral angiography was available by then. All these patients who were irreversibly comatose and showed absent cerebral circulation, they all had asystole, none of them survived. Among the few patients in whom there was an intact cerebral circulation, some of them survived. So there was a basic definition that these two people made, that absence of cerebral circulation meant definite death, how long you maintain the patient. But some of them with a persistent cerebral circulation could survive. That is what they proposed the neurological. Brain death is simple. It is neurological criteria of death, as simple as that. Fine. So why does this happen? So there is a mismatch in our cardiopulmonary resuscitation. See, of course, many of you present in this webinar would have had the pleasure of restarting a heart. Somebody had a cardiac arrest, you go there, you defibrillate, do something, cardiac CPR, you start CPR, the cardiac starts. And maybe with a pacemaker, the heart functions on its own. But once it goes beyond the time limit, there is permanent damage to the brainstem. The respiratory center is permanently damaged and the patient is not able to breathe. The heart is functioning fine. Is the CPR successful? I do not know. Patient is not able to breathe on its own. Yes, we have put in an endotracheal tube with a ventilator. We are maintaining the respiration, but will the patient breathe again? That is the basic question. The defining moment between life and death. Yes, heart is going on. As on date, we are incapable of making such a patient take one spontaneous respiratory attempt and make him breathe again. That is where this concept comes. So we have gone back from this cardiac heart sounds stethoscope for probably 100 years, gone back to respiration to be the defining moment of life and death. So life is pleasant, death is peaceful. This is what the transition is troublesome, is what Isaac Asimov, a Russian-born American writer, told, and that is more than true now. So if we have been resuscitated, put on ventilator, permanent brainstem damage has occurred, when is death going to happen? Dying has become a process. You are put into a process. Where is the end point? Today, I can assure you that if in an ICU and if you are affordable, we will be permitted to die only when ECMO is withdrawn or CPR is withdrawn or not provided at all in the first place. Otherwise, it is going to be an on and on and on phenomenon without an endpoint. So at some stage, it became very clear that death is not a diagnosis anymore made with a stethoscope simply, but it is a decision a physician or an intensivist has to take in discussion with the relatives of the patient. We were compelled to redefine death at some point of time in the early 1960s, let me tell you, because of three factors. One, these patients were, I won't say occupying, were with these life supports and they are unlikely to survive. Whereas there were patients who had a better chance of survival, or at least a chance of survival, who could benefit with utilizing these resources of ventilator and ICU beds. Number two is, we have demonstrated to the world that yes, organ transplant is a possibility and a successful one. There are a long list of patients who are waiting, and these brain dead patients could be potential donors who could be able to sustain life. These are the reasons why we were compelled to redefine death, because events linked to death were no longer valid. Concepts related to death of all organs are also no longer valid scientifically and legally. That is where we are today. But there is a dilemma. Physical death, as we have seen, is reversible. We can put in somebody on a ventilator, put in a pacemaker, restart the heart, put in ECMO, and we can sustain it. But the presence or absence of vital signs, somebody who has a pulse rate, beating heart, measurable blood pressure, measurable saturation, oxygen saturation, can be declared death legally. Clinical death need not be sufficient. As scientific knowledge and medicine advanced, formulating a clearly defined medical definition for death became more and more difficult. But at the same time, where is this dilemma? These patients, if you had done a craniotomy, as I have done on many occasions, 9th day, 10th day wound has completely healed and you are able to do a suture removal or a stapler removal. They will fight infections, they muturate, they defecate. And as Professor Palni sir has mentioned, a pregnant lady, if maintained properly, brain dead, can still give birth to a live fetus. Can we call them dead? That is the dilemma which we had. So, what was the earliest report of brain death? It was made by Maimonides, a 20th century Arabian physician scholar. See, in those days, decapitation was a form of punishment, and a scholar and a physician has to be present while enacting these punishments. And Rabbi Maimonides was one of them. See, when do we consider somebody as dead when there is a decapitation? Is it at the time the head is severed of the body? The body will still throw around. Blood will pour out. That will be beating heart for a few minutes. When is the time of death? So Maimonides made a very important observation, because he has witnessed so many decapitations, and said, at the moment of decapitation, whatever happens to the body, it throws around, blood pouring, limb movement, patient stopped breathing. And he for the first time documented that brain, by way of controlling the respiratory center, should be considered as the central organ that defines brain death. And after 800 years, it was validated by the French physicians Mollaret and Gola. The physiology of death is revised today. It can be a primary or secondary brain event, primary or secondary respiratory event, primary or secondary cardiac event. But whatever the cause or etiology, death happens because of absence of cerebral circulation, irrespective of whether the cardiac circulation is being maintained or not. If the heart stops, cardiac circulation stops, cerebral circulation stops, death happens. If the heart is beating, it's a pulmonary problem, cardiac problem, cerebral circulation has stopped, patient is dead. That is exactly where we are today. The primary event is arrest of the cerebral circulation through whatever means, whether it is brain, pulmonary, or cardiac, is completely different. So there is a concept change today. CPR and ECMO had defied historical concepts of death determination. Death can happen in many situations, whether CPR or ECMO is considered, and I am sure everybody will agree with me that brain happens to be the central organ as far as the defining moment of life and death is concerned. So, brain death, because of the absence of cerebral circulation, which is the primary event of death in any possibility, whether it is cardiac, pulmonary, or brain injury. So, it is equivalent to death. That is where we have come so far. So, potentially, these patients will be only in the ICU. All these patients are on ventilator because they are not able to breathe. This is fine. What is the most important aspect? It is a neurological criteria of death. Any patient with GCS3, absent brainstem reflexes, no respiration, cough reflexes, you simply cannot diagnose it as a brain death. The first and foremost is this irreversible or permanent comatose stage of the patient should be because of a neurological cause. So the first point is imaging of the brain. You do a CT brain and an MRI, and there should be a major finding in that image, which should correlate with the neurological status of this patient. That is the most important step. And most of these patients in ICU who do not need a sedation or muscle relaxation, they're happy on the ventilator to be on the ventilator. They don't fight the ventilator, then they are potential patients. The first point is GCS 3/15. The image findings, as I told, CT or MRI, should have a major catastrophic finding, which is consistent with the clinical status of the patient. They should have a fixed dilated pupil. Spontaneous respiration should be absent. Most of them have diabetes insipidus, not always, because of the neuroendocrine disturbances. Most of the patients which I have seen certified had diabetes insipidus, and that is one point which elicits, which raises the doubt that whether this patient could be brain dead. And most of them has cardiovascular instability and need vasopressors. The most common etiology in our country is trauma, but in abroad, it is all non-trauma. Here, the second most common is stroke and aneurysmal rupture with diffuse SAH. And if you see scans like this, massive acute subdural hematoma, massive midline shift, all these things, intracerebral hematoma, intraventricular hematoma, this is an aneurysm rupture. These are, if the scan is like this and the patient is like this, then you can confidently say, yes, the clinical status of this patient is because of brain damage. So next you go, once you have the imaging criteria correlating with the clinical status of the patient, then you go to brainstem reflexes. No response to pain fixed. This I will explain to you. Pain should always be given in the supraorbital ridge or within a cranial nerve distribution site. Never in the sternum or the arms or legs, pinching in the abdomen, pressurizing the sternum. These things should be avoided. We are testing brainstem reflexes. Pain should be given only within a cranial nerve distribution area. And most commonly, we give it in the supraorbital ridge. When there is no response, then it is right. Pupil should be dilated and not reacting. Unequal pupil, asymmetrical pupil, pinpoint pupils, these things are not consistent with brain dead. Should be very, very clear. There should not be no light reflex. And Sarah has pointed out, doll's eye reflex should be absent. We do the cold calorie test. When you instill cold water in the right ear, the eyes will slowly deviate to the right side if the brainstem is intact and there is a fast component, correcting fast component that is present. If there is no deviation, given the cold calorie test on the right ear, do it on the left ear again after 5 minutes. And if there is no eye deviation, the cold calorie test becomes positive. You test the corneal reflex, which tests the 5th and 7th cranial nerve. Then the gag reflex, which will test the 9 and 10. No spontaneous respiration. Now you have come to a stage of yes questions. Etiology known? Yes. Image correlation present? Yes. Toxic causes absent. That I'll come to you later. Metabolic parameters within range? Yes. Temperature more than 35 degrees centigrade. All the no questions. No alcohol in last 6 hours. No sedatives. No narcotics. No muscle relaxant given in the last 6 hours. And all brainstem reflexes are no. This is the stage where we have to look at other aspect. There is something called an indeterminate movement. 1/3 of these patients with brainstem death can have indeterminate movements of their limbs, fingers, or hands, or anything like that. Can be finger jerks, abdominal reflexes, muscle reflexes may be present, plantar may be present. Sometimes the patient may attempt to sit up like the Lazarus sign. These are things which you will need experience to find out. If you look at this, this is one of our patients who happened to be a donor later. This is a patient. He had spontaneous limb movements even without pain. But these are spontaneous reflexor movements and nothing. And we, in fact, certified this patient as brain dead, and he was one of our organ donors. This is another patient. If you look at that, the right hand, she's keeping it flexed and firm. It doesn't fall off just like that. It is not flail. It is not flail. You can see she's keeping it firmly. If you bring down the hand also, after some time she will do this. These are all indeterminate movements. If you look at this patient, look at the thumb. There will be a subtle movement of the thumb. I have so many videos of such things, which are indeterminate movements, which I myself have examined and determined as brain death. And all these patients which I have shown as indeterminate movements, they've all been organ failures. So this is another patient. So what I do is, I simply do not examine for absence also. This is a plantar reflex in a brain dead patient. That is me examining. I look at what is absent. At the same time, what are the indeterminate movements that is present also, always look. Always look. So that the patient who is around you, after all these checkings, when I say the patient is brain dead, and later when the patient witnesses this on its own, then they will understand that yes, these movements are present when even I have examined and pronounced them as brain death. So it needs careful examination. It is not about what is absent alone. It is what is at least present that you should do. So when will you defer brainstem death certificate? When the brain imaging is normal, don't do. Fever more than 101 degree Fahrenheit, patient is hypothermic, marked meiosis, myoclonus, rigidity, abnormal lab values. I'll come to this. When there is a drug screening positive, these are all situations where you should defer. So now, after all this, we have come to the apnea test. Apnea test is nothing but stimulating the respiratory center to its maximum effort, and the most potent stimulator available is carbon dioxide. You increase the PaCO2 value beyond the limit and make the patient make one spontaneous respiratory attempt, and the patient is not making, then that apnea test is positive. Anytime you want to do an apnea test, these metabolic parameters should be within this range. If it is outside of this range, then you are not supposed to proceed with an apnea test. pH is 7.3 to 7.4. These are all our Tamil Nadu standard guidelines. Glucose, sodium 120 to 160, potassium, PO2 should be more than 75, PCO2 between 30 to 45. Only when this range is available, you are proceeding with an apnea test. Otherwise, you are not doing. The vitals, core temperature more than 35 and 95 degree Fahrenheit. In our guidelines, systolic BP of more than or equal to 90 with a consistent MAP of more than 60 is needed throughout the test. So what we do is, we underventilate the patient so that the PaCO2 is slightly on the higher side, somewhere above 40, between the 30 to 45 range. This is done so that the test becomes more validated. Test becomes more validated. And the first apnea test is done after identification 6 hours later. So we do a baseline ABG. Then when the parameters are within the range, we disconnect the patient from ventilator for 8 to 10 minutes. And the only thing we look at is whether the patient is able to breathe or not spontaneously. So the most important person looks at the respiratory movement. And every minute, there is a person, a doctor, who says 1 minute, pulse rate is this, BP is this, saturation is this. Every minute, there will be a count. After 8 to 10 minutes, we do an ABG and reconnect the patient to the ventilator. And based on the PaCO2 of the pre-test and the post-test, we certify someone as brain dead. And mind you, more important aspect is the duration between the two tests. The first positive apnea test and the second test is, if the patient is more than 18 years old, 6 hours. 31 days to 18 years is 12 hours. Term newborn to 30 days is 24 hours. There is no consent needed to do an apnea test. When will you stop the apnea test? When the systolic BP goes below 90, significant cardiac arrhythmias, SpO2 drops below 85%, the test is aborted, and aborted test can be repeated after 6 hours. When it is considered positive, no spontaneous respiratory attempt by the patient, and the post-apnea PaCO2 is more than 60, or there is an increase. For example, let us assume the test started at 38. Post-apnea test PaCO2 is 59. It is still positive. The other situation is the test started at 45. The post-apnea is 61. The difference is only 15 or 16, but still it is positive because it has crossed the absolute value of more than 60. When is it negative? The only situation apnea test will be negative is when the patient takes a spontaneous respiratory attempt during the apnea test, and when there is strong clinical grounds, a negative apnea can be repeated only after 24 hours. When is it considered indeterminate? The patient has not taken any respiratory attempt throughout the apnea test, but the PaCO2 rise is insufficient. For example, the test started at 44. The post-apnea test is 52. Then it is not enough rise. Then in that case, we determine it as indeterminate, can be repeated after 3 hours. So when will you certify somebody as brain death? When all criteria of this irreversible coma is present, all brainstem reflexes are absent, apnea test first and second are positive apart from 66 hours, all yes questions have yes as answer, all no questions have no as answer. The time of death is the ABG by which the PaCO2 criteria by which we say the patient has become brain dead in the second apnea test. That is the time of death. Yeah. There are certain red flags. When there is a cardiac arrest, patient is revived, patient remains all brainstem reflexes absent. You cannot just like that identify that patient. We have to wait for 24 hours. Even after 24 hours, the patient is in the same clinical state, then you can identify that patient as brainstem death, and the first apnea test can be scheduled only after 12 hours, not 6 hours in other situations. Hypothermia also is the same. For example, neuromuscular disorders, a cobra poisoning or neuromuscular junction, there is a permanent damage. There has been reports stating that even after 8 days, it has recovered. So in such situations, we wait for 72 hours, do an ancillary test, and proceed with certification. Decompressive craniectomy, any surgery, within 6 hours, we cannot diagnose, only after 6 hours. And within 6 hours of loss of brainstem reflexes also, we should not diagnose. These are the red flags which we have. Red flags does not mean they are not brain dead. We should exercise some more caution. So when will you do an ancillary test? Extensive bilateral facial-maxillary injury, high spinal cord injury above C4, is a pulmonary problem, aspiration, pneumonitis, severe pulmonary edema, patient requiring high FiO2 or high PEEP to maintain barely the saturation. With 100% FiO2, with a PEEP of 10, patient will barely maintain 92 saturation. The moment you disconnect, is going to desaturate, and you have to abort the apnea test. Chest injury, neuromuscular disorders, and eye. Examination of eye is very important. For example, the cranial nerves which we test for eye brainstem death is only 9. 2, 3, 4, 5, 6, 7, 8, 9, and 10. If you are not able to examine the eye, you are not examining 2, 3, 4, 5, 6, 7, and 8. That is 7 out of 9. Your neurological examination is incomplete. In such situations, we have to look at the ancillary test. And these are some of the CTs of brain dead patients. It's not a diffuse SAH or a CT angiogram. This is clotted blood within the blood vessels, which appears like a SAH. The other ancillary, we have done away, we have stopped doing EEG, transcranial Doppler, and these nerve conduction studies, all these things because of lot of ambiguity. As per the guidelines today proposed by the government of Tamil Nadu, we have stopped all these things. Cerebral angiography, DSA, and MR angiography are the 3 things which we recommend for ancillary testing as per the government guidelines. And we do a cerebral angiography, we do something called a 4-point score. We see whether there is a contrast flow in the right and left M4 segment of middle cerebral artery, right and left internal cerebral vein. If there is no flow in all these 4 vessels, we give a score of 4/4 and it is brain death consistent. If it is 3/4, 2/4, 0/4, 1/4, it is negative. This test has a 100% specificity. There is no possibility of a false positive testing here. Even though the sensitivity is less, 100% specificity. And sometimes this false negative occurs in patients who have undergone VP shunt, open AF in case of children, or a surgery or large fracture. DSA remains the gold standard, but it is recommended to do a cerebral angiography if there is doubt, yes, you can go ahead with the digital cerebral circulation angiography. These are the images where you can see there is absent internal cerebral circulation. And when is the time of death if you do an ancillary test? Ancillary is only supplementary. It does not replace the clinical criteria. We do the performable neurological test. Before shifting the patient for the CT angiogram to the radiology suite, we do all the clinically possible tests, document absent clinical brainstem reflexes, do a CT angio, come back to the ward, again do all these brainstem reflexes testing, and it is the end of the brainstem reflexes testing. Suppose the patient has come to the ward after CT angio at 8 p.m. You complete the test as 8:30. The time of death is 8:30. You may get the report at 9 o'clock, 9:30, 9:15. But the time of death happens to be the clinical death time of 8:30. So time is given. As Sir has mentioned about the dead donor rule, it was proposed by 1966 by Guy Alexander. It meant organ procurement should not result in death of the patient. It means, can somebody donate their heart, a living person? It amounts to suicide. It amounts to killing by the harvesting physician. That should not be done. Only a dead patient can donate all his organs, particularly the single organs like heart and lung. That is the reason we give the second apnea test as the time of death. By putting that time as time of death, we permit the retrieving surgeons and transplant surgeons to harvest the heart. Otherwise, it will amount to killing. That is what this dead donor rule tells us. So when will you evaluate a patient to identify? Suppose the patient has come to us at 1 a.m. into the hospital. Even at the time of arrival, it is brain dead. We cannot identify that. We have to wait for 6 hours because inadvertent muscle relaxant or sedation might have been given in the ambulance on the way. So only after 6 hours, we can identify. Identification to apnea is first is 6 hours. In other situations, it can be 24 hours. And patient may be on ECMO. These are all special situations and beyond the scope of this topic. So I'm skipping all those, how to diagnose brain death in an ECMO patient. Unequal people should not be taken up. And sometimes when you have posterior fossa hemorrhage, a brainstem hemorrhage, pontine hemorrhage, cerebral ICH or IVH, it's better to do an ancillary test. In pregnancy, as Sarah has mentioned, it is the viability of the fetus that is most important and nothing else matters. And in children, ancillary test is limited by paucity of data. American Academy recommends only radionucleated cerebral flow. All other things are not validated. And this is our youngest donor, 18 months old child from Andhra, admitted in MMC, who donated. And there is no age bar. This is a 95-year-old man who happens to be the oldest donor in the whole world. His son was also a brain dead, became brain dead and donated. This is our oldest donor in India, an 85-year-old man who donated his liver. This is a 78-year-old lady who donated all her organs. The recipients are living well. This happened last year at Ames. And in MMC, this is our oldest donor, happened to be a 72-year-old man. All organs were harvested and the recipients are doing well. And all these recipients have a wonderful life. These are the transplant games. Last year, it was inaugurated in Kochi, the first transplant games by Mumati. These are all transplant recipient patients who won the marathons, the sprint and other things. So to remember, there is life even after brainstem death. 1,000 donated kidney means not only 1,000 CKD patients benefit, but also 1,000 healthy people do not go under the knife, do not go to the surgical table to be operated and have their organ removed. It is a social responsibility of our physicians. And Tamil Nadu, even today, you can Google the word kidney vakam. You will find it is our own Willy Vakam, where kidneys were available for 25,000 to 45,000 rupees. The head of the family would have donated the kidney of the mother, wife, sometimes the daughter also. More than 95% of donors were women. And this is what triggered our program, which we started in 2008, October. This is the trigger point. The then Chief Minister said very clearly, nothing doing, we have to do something about this. And that is how we all sat together and started this program. So I gratefully acknowledge extremely dedicated neuroconsultants, intensivists, anesthesiologists, the entire transplant team, administration, most importantly, patients who were donors, and the relatives who took the noble, valiant, gallant decision of donating organs of the deceased. This program needs passion and social responsibility. To conclude, We have looked at the physiology, the concepts, central organ, the passion that needs to run this program. Should be an uniform decision, team effort. The most important aspect of any disease donor program is altruism and how to keep this burning. See, we belong to a noble profession. We are able to take an organ from a dead person, brain dead person, transplant it to another dying person and make him live. That is the beauty and nobility of our procession. So to keep this flame burning, transfer the flame. One candle can light many. So this is not a trivial thing to ignore or a massive thing to not to study. And these are my references. And thank you so much. I thank each and every one of you for your patient listening and the wonderful opportunity. I thank IMA, Rajesh Babu, Vikram, Professor Dr. Balamurugan, my fellow speaker, Palni sir, and each and every one of you from the bottom of my heart. Thank you so much. Thank you.
Thank you very much, sir. Ragahavendra, sir, you really done a very detailed. My friend Dr. Pazhani was little, I thought he was a little elaborate, but I think you did very elaborately. And since it's a PG class also, I think it's quite worth having listening slowly also, not to run up fast, and a lot of newer things to learn today. And two speakers, both Dr. Pazhani and Dr. Ragahavendra, you really done very well. Yeah, this is my just a query to Dr. Pazhani. Pazhani, we are talking about so many guidelines, this thing from American Association of Neurology, Brain, everything. Don't we have an Indian or guidelines regarding this? Whenever we code about the American guidelines for everything. Do we have anything on Indian guideline?
If you see the guidelines I put, and as well as what Dr. Professor Ragahavendra told, the guidelines that follow in Tamil Nadu, more or less same. Because we learn and allopathy is basically a Western medicine. And all the clinical criteria like coma, loss of brainstem reflexes and apnea, that's the same thing we follow here. And only the ancillary test, everything I think more. And I think that even only thing is there are some difference among different states in the United States in certain few things. Otherwise, uniformly it is followed. If you go to other countries also, there's a marginal differences as per their traditional and cultural issues. Otherwise, most of the criteria applicable to most parts of the world.
The Indian perspective, do different states have different criteria on this?
No, I think more or less.
Something I remember Dr. Ragahavendra was telling whatever Tamil Nadu says, Tamil Nadu follow. I mean, is it only for Tamil Nadu, or is it the national guideline, or is the state-wise guideline? Is it something like this?
Sir, actually, every state has different guidelines. Sir. And in fact, before this 2023 April 4 guidelines, which we revised, the value was 55 for PaCO2 and 15 difference. We changed that. Constantly, we continue to revise these guidelines. And the last one happened to be in April 2023. And there are many other states which have different guidelines. There are minor differences, of course. There are minor differences. And more or less, it is the same. The major difference between other states is only the state of Gujarat and Kerala, they permit withdrawal of support if somebody is declared as brain dead and not willing to donate their organs. There is a clear-cut law and a government order which says they can withdraw the ventilator if they are not willing for organ donation once they are declared as brain dead. No other state in India has that. In fact, in Tamil Nadu, we are not permitted to withdraw support. The patient is not willing, we will continue. Even after 3 or 4 days in MMC, we have seen on many occasions, the patient will finally, the heart will stop. After 4 or 5 days, not willing for donation. The death time will be the brainstem death, second apnea test time. But we make a small note in the case sheet that the heart stopped on this date at this time. That's it. It is not the time of death. We just make a mention. The death time will be that only. So Kerala and Gujarat have a clear-cut law that permits them to withdraw support for somebody who is not willing for organ retrieval. Otherwise, with minor differences, there are things, but every state has a different guidelines.
Is it applicable for government?
Sir?
So is it applicable for the government hospitals or for the private also?
For the whole state. There is a SOTO, that is State Organ Tissue Transplant Organization for every state. Then we have ROTOs, 5 ROTOs, regional organ. For example, Chennai, Tamil Nadu is the ROTO for Maharashtra, Telangana, Andhra, Karnataka, Kerala, Tamil Nadu, Puducherry, and Andamans. So we have ROTOs. Among these ROTOs, there are different criteria for each SOTO. And even some institutions, for example, AIIMS, Delhi, and PGI, they have their own criteria to identify and certify brain death. So it is just that they should have some form of a uniformity. But this transplant guidelines, which I spoke about today, is for the whole state of Tamil Nadu.
The recent American Academy of Neurology Guidelines 2023 I mentioned, whatever criteria Professor Ragahavendan mentioned, it tells the same thing.
Yes,
Like,
sir.
so I think more or less the basic concept is more or less same all over the world. There are some minor differences.
Probably each part, the cultural, as Dr. Ragahavendan was telling, the cultural perspectives and the emotional perspective of the patients and the behavior, everything little changes. Probably that has to be really, the sentiments and the culture of people have to be really taken into account. But ultimately, we have to donate with with a noble cause and the heart has to be wholeheartedly, we have to do the things. That's very, very important.
Absolutely. Absolutely.
Organ donation is not a simple thing, and it's really a great great job or something like someone does it means it's really something very, very commendable act. In spite of the improvements in the knowledge of the transplant and more number of people requiring transplants, organs, and so it's really a great thing. And Pazhani, and does the NMC, National Medical Commission, does it have anything to say on this? Any guideline? Have they formed anything on this?
I think the guidelines, as Professor Ragahavendan was mentioning, like the SATO, the RATO, and there is something called NATO also, national organization also there. I think they only deals with all these kind of recommendations.
Sir, now we will go for the second
Yeah,
question,
yes,
sir.
sir.
1 minute, sir.
Yes, sir.
Basically, the NOTO deals with the basic framework of how to do things, the procedurals, the SOPs and other things. And NOTO has clearly mentioned that it is up to the SOTOs to have their own guidelines. There's nothing uniform that NOTO has proposed so far, because I'm the legal and ethical representative of NOTO. And even in January, we had a meeting. So based on, as you have rightly pointed out, Balamurugan sir, it is on the ethical, cultural, and ethnical, and so many aspects. India is a vast country. So based on that only, regional wise, these guidelines are being formed. Regarding pregnancy, depends on the viability of the fetus. See, 24 weeks is what we take as viable fetus. Once it is crossed, then it becomes the family decision. We have had occasions where families are willing to donate the organs, but don't want the child. Then we do a hysterectomy, take
Mute everyone, please.
to the home, put it in a child welfare committee, go ahead with that. Sometimes they're not willing for both the mother as well as the child also. Then we cannot do anything, we just wait. Sometimes they would want the child, not donate the organs. In such cases also, we do a hysterectomy, take out the child, and based on the so viability is the most important aspect as far as a patient with pregnancy is concerned. And then it is the family's decision about the child. So these are 2 divisions which we encounter, and on 4 occasions we have encountered, and every time it was a different decision. It happened differently on all those 4 occasions. So there is no hard and fast rule in special situations. And in ECMO also, when a patient is on ECMO, see, the carbon dioxide is constantly being filtered out. Oxygen is being supplied. So how do we do an apnea test? You stop the carbon dioxide is filtered out. There is going to be a fall in the PaCO2. So what we do is we infuse CO2. We add another chamber to the oxygenating chamber. We infuse carbon dioxide. For in 1 or 2 minutes, at 100 ml per hour rate, per liter rate, the PaCO2 jumps to 80 plus. then we stop it. So the PaCO2 will start falling from 80, and then when it reaches 61, there is no respiratory attempt, then we declare the patient as brain dead when the patient is on ECMO. So it is a reverse of the apnea test. That is how we do it. And the most important differentiation is a patient on ECMO, we don't do a CT brain. No brain imaging is done. It is purely on clinical criteria. Because almost 70% of patients on ECMO at some point of time will develop intraventricular hemorrhage, intracerebral hemorrhage. On ECMO, they'll become brain dead. There's no way of doing an image. So there are a lot of situations we come across, and every case has been always different. Since that was a related pregnancy, I thought I will let you know this. So every situation demands a different approach. We still learn.
Sir, when the patients are on this pacemaker, your experience about the brain death certification, sir?
Sir, pacemaker does not come into the purview at all, sir. Patient GCS3, brainstem reflexes absent, there is a major finding in the brain imaging, then that is fine. People have asked me, what about suspended animation? I say this patient is in suspended animation. This patient may be drowned. I tell them very clearly. When there is a gross hemorrhage or a finding in the brain image, then it cannot be suspended animation. Somebody asked me, patient would have drowned, what is happening? Then the brain image is normal. So most important thing is neurological criteria clinically. The next thing is matching it with the image. If the brain image is normal, you are not proceeding because this is purely neurological criteria. Whatever happens below that cerebral circulation is immaterial. Unless there is a toxic cause, like a sedation or muscle relaxant or other things.
So I think we'll take up your question, sir.
One more question.
Yeah.
Sorry, for Ragahavendan. What about the brain imaging means CT scan or MRI? If it is normal, we take it as a diffuse axonal injury. How will you diagnose that? You go for an MRI or just go with the CT alone?
See, even in diffuse axonal injury, the CT brain is never normal. There are always the small punctate contusions at the gray-white matter junction. That is stage 1. Or stage 2, we have that small IVH. Because of corpus callosal tear, the blood trickles, or a brain contusion. Sometimes we have bleed in quadrigeminal system.
But will you go for MRI to rule out?
We do not go for an MRI. We do not.
So basically,
our traditional teaching is CT brain normal, low GCS. We take it as DAI.
No, the present day teaching is CT is not normal in DAI.
But it's a
we have to look for the findings. May not be gross findings.
Neurosurgeon can find it, but most of the time, radiologists give us a normal.
That is why it is a domain of the neurophysicians and the neurosurgeons.
Okay.
It cannot be diagnosed with anybody else.
Sir, so do you think that when you are clinically able to come to a conclusion the brain dead, do you think this doing a CT and MRI and all are mandatory?
It is absolutely mandatory, sir. It is absolutely mandatory to do a brain imaging. Only when there is an image correlation with the clinical status, we proceed. If there is a doubt, we can do a CT angio or a DSA and confirm absent cerebral circulation. That is an objective finding. But one image of the brain, whether it is a CT or an MRI or a CT angio brain or a DSA brain, is absolutely essential. Whether you are going by the apnea criteria or the ancillary criteria, one imaging of the brain is absolutely essential.
Rather, one more question. Is it you accept CT angio as an equivalent to DSA?
Yes, sir. The specificity of CT angio is 100%. The sensitivity is 85%.
Yeah.
So there cannot be a false positivity at all. See, because what happens in CT angio is, after 24 hours, there is a lysis of blood within the large vessels. And the pressure with which the contrast is injected, there can be an apparent flow.
Okay.
That is the reason we look at the M4 segments bilaterally, not the M1, M2 or M3.
Okay.
And the most sensitive and specific finding in an angio is absence of flow in the internal cerebral vein, not the vein of Galen or the basilar artery or other things. It is the internal cerebral vein.
Okay.
So it goes to the fourth segment of the arteries and the internal cerebral vein. It is the center. It comes to the center, center of the brain, and there is an absence of flow. Then that is 100% specific. Even though the sensitivity is slightly less, that doesn't matter. Many times you see VP shunt patients, decompressive craniectomy, and children with wide open anterior fontanel, the ICP doesn't rise to that extent so that the flow is completely stopped.
Okay.
There they develop false negativity. We are not able to certify. That is finished, but no false positivity.
Okay.
There is one question, sir, in the chat box. They are asking,
Yes.
sir, when a person is certified as a brain dead and not willing for donation, time of death is question mark. If it is a time of certification of brain death, and if the patient relatives take him on DAMA before his heart stops, what should be written on the summary?
See, the time of death is always the time of the second apnea test at the time when was the ABG was drawn. Okay. The other aspect which you have raised is this discharge against medical advice. This DAMA of a clinically brain dead patient is possible from a government hospital to another government hospital, from a private hospital to another government hospital, never from a government hospital to a private hospital. That is point number 2. In case a patient has been declared as brain dead after 2 positive apnea tests, the patient is not willing to donate. The patient says, no, we are going to a government hospital. Then, as per the Supreme Court guidelines, the hospitals, it is the hospital's duty to have proper transport arrangement to the government hospital. Question, it is a very, very important question, I understand. See, the time of death is always the time of the second apnea test. That is one thing we are very clear. Okay. And the second point is, a clinically brain dead patient can be transferred from a private hospital to a government hospital, from a government hospital to another government hospital, but never from a government hospital to another private hospital. This is point number 2 as per law. The third scenario, third point which I want to make is, a patient has been declared as brain dead after 2 positive apnea tests in a private hospital. Let us assume the patient is not willing for donation. The patient wants to go to a government hospital. So in this situation, as per the Supreme Court guidelines, it is the hospital's duty to facilitate the transfer of this patient to a government hospital, even though the patient is brain dead. So now comes the point about the time of death. Let me be very clear. A death certificate can be issued only on 2 situations. One, the body has gone through the mortuary, the heart had stopped. At the time of coming out of the mortuary, the death certificate can be issued. It will be given to the corporation. The corporation can give the death certificate as per the time. Whether it is the second apnea test or not is a different question. Patient has not donated. So the second apnea test will be the time of death. In the other scenario which I have mentioned, the patient after 2 apnea test positive declared brain dead is going to a government hospital. In such a situation, what the law says is, when the heart is harvested, that patient can be declared as death as per the second apnea test time. When the heart is not harvested, for example, if the patient is going out of that private hospital with a beating heart, yes, I agree, he has been declared as brain dead. As per law, the time of death is the second apnea test. But the patient has left the hospital with a beating heart, and I tell you, the second apnea test time of death is for the purpose of organ retrieval and not for any other things, then the patient cannot be declared as per the second apnea test in that private hospital. Because death can be certified only when the heart is out of the compound, harvested, or intact heart not beating coming out of the mortuary. So in such a situation, when I receive a patient in MMC who has been already declared twice, 2 apnea tests done and declared as brain dead, what we do is we wait for the mandatory 6 hours. time period for identification. Suppose patient gets admitted at 1 a.m. We examine the patient at 7 a.m. and the patient happens to be brain dead. We do a third apnea test. And if the third apnea test is positive, and in these 6 hours time, we write to the transplant. We write an email to the transplant asking whether the transplant authority is validating the previous 2 apnea tests done in the other hospital. If transplant says, yes, I have gone through the records, those 2 apnea tests are valid, we are agreeing with that, then with the third apnea test, we certify the patient as brain dead in our hospital. That is at 7 a.m. The time of death becomes 7 a.m. If transplant says, no, we are not able to access those records or we are not satisfied, then we treat it as a fresh patient. 1 a.m., 7 a.m., we identify. 1 p.m., we do first apnea test. 7 p.m., we do the second apnea test and declare at 7 p.m. So the point here is time of death, if the patient remains within the same hospital, is the second apnea test time. Whether the patient is willing and the heart is harvested and gone out of the compound of that hospital, or non-beating heart, patient coming out through the mortuary without willingness, then it becomes second apnea test positive. But if the patient goes out, discharged against medical advice with a beating heart, then the time of death becomes null and void of the previous hospital or second apnea test. That is it. That is what the law says.
So
So,
here,
Yadagi,
what is
you
the
understand
point?
how complicated is it?
Can I ask one question?
Yes, sir.
Sir, we as a pediatrician are always concerned about the birth time. What is the legality of the death time, sir? You have discussed length, the death time. What
Yes,
is
sir.
the legality of the death time, sir?
Sir, the legality of death time, sir, it is the heart stopping time through the mortuary. In other words, but for the deceased donor program
So
alone,
why are you mentioning
based
the word
on the,
mortuary, sir?
sir,
Why
that
are
is,
you mentioning the word mortuary?
sir, only when the patient goes through the mortuary, whether it is an MLC case or non-MLC case, the death memorandum is given. Based on the death memorandum issued in the mortuary only, they can go and apply in the corporation.
Patient do not die in
Sir,
the
one
mortuary,
doubt.
no, sir.
Patient do not die in the mortuary. Patient dies in
Yeah.
the ward only.
Yeah.
Ward only. But it is not given in the ward. Through the RMO, the death memorandum, body, everything goes to the mortuary. And when receiving in the mortuary only, these things are all given, based on which they can apply in the corporation.
Probably
Sir,
I think
one
this
doubt,
needs to
sir.
be modified.
Sir, physically, the body may not go through the mortuary in a non-MLC case. But an entry is always made in the mortuary.
But whatever it is, I think this needs a modification, sir. Patient dies
Yes,
in the ward and ICU. And
Yes, sir.
probably that time have to be taken rather than
That is the
going.
time of death, sir. That is the time of death. I completely agree. But those certificates and memorandum will be given only when the patient is going out of the mortuary. Because in a brain dead patient can still go out with a beating heart to another hospital. Then that cannot be taken as death time.
Sir, one clear
no,
doubt is, sir.
And to
one
answer
doubt.
SAR's question, the death time க்கு காரணம் வந்து SAR சொன்ன மாதிரி இந்த dead donor rule தான் சார். Dead donor rule படி donate பண்றவரு அந்த டொனேஷன்னால இறந்து போக கூடாது. That is what the dead donor rule says. Exactly. So டெத்னு ஒருத்தரை டிக்ளேர் பண்ணாதான் அட்லீஸ்ட் சிங்கிள் ஆர்கன்ஸ் லைக் ஹார்ட் லங் இதெல்லாம் எடுக்க முடியும். அண்ட் டெத்னு நம்ம டிக்ளேர் பண்ணலைன்னா அயோட்டிக் கிராஸ் கிளாம்ப் போடுறப்பதான் இட் அமௌண்ட்ஸ் டு கில்லிங். That is against Hippocratic oath, that is against the social order of physicians at all. So that is the reason we certify second apnea test as the death time. We are giving permission for someone to put an aortic cross clamp and retrieve organs if the patient happens to be willing, relatives happens to be willing.
First question, sir.
Yes,
Sir,
Rajesh
now
Babu
question
sir.
கேட்கிறேன், sir.
கேர்ஃபுல்லா இருக்கணும் சார், ரொம்ப
ரொம்ப
கேர்ஃபுல்லா
கேக்குறதுக்கே ரொம்ப காம்ப்ளிகேட்டடா தெரியுது.
கேர்ஃபுல்லா இருக்கணும்.
Sir, one
Rajesh Babu
question,
sir.
sir.
Okay. Yes, sir.
Sir, one question, sir. One last question.
Yes,
Sir, இப்போ ஜென்ரலா வந்து இந்த பிரெயின் டெத் வந்து ஆர்கன் டொனேஷன் கொடுக்குறாங்க இல்லைங்களா, அவங்களுடைய டெத் டைம் வந்து எந்த டைம்? தி ஆப்னிக் டெஸ்ட் தான். which time we will declare as death time?
apneic test time தான் சார்.
Second apneic test.
Yes, sir.
அந்த
அவங்க
டைம் வந்து
willing-னாலும் சரி willing இல்லைனாலும் சரி அதே ஹாஸ்பிட்டலுக்குள்ள ஹார்ட் நின்னு போச்சுன்னா அதான் டைம். ஹார்ட் ஹார்வெஸ்ட் ஆயிடுச்சுனாலும் அதான் டைம். அயோட்டிக் கிராஸ் கிளாம்ப் போட்டாலும் எதுனாலும் செகண்ட் அப்னேட்டஸ் டைம் தான்.
Okay, sir. I think, sir, we had a wonderful discussion and a lot of learnings. Till we need to learn. அவங்களுக்கே ப்ரொஃபஸருக்கே வந்து இன்னும் சிச்சுவேஷன் வரும்போது மேனேஜ் பண்றது கஷ்டமா இருக்கு. ப்ராப்ளி நாங்களாம் வெளியில இருக்கோம். Probably this insight will help us to when some of our relatives or doctors ask us. Probably thanks Rajesh Babu sir for a wonderful arrangement. Thank you, speaker. I will pass on this thing to my secretary, Dr. Jalil Ahmed sir. Are you there?
Yes, sir.
Jalil Ahmed sir,
Vote of thanks, please.
Sir, that was an excellent deliberation by the stalwarts, the neurosciences stalwarts. So this is the time to say what are thanks for all the viewers and my chairman and then. So dear esteemed senior members of this forum, colleagues and my dear friends, good evening to all. On behalf of IMA Coimbatore and AMS Wing, I extend my heartfelt gratitude to our esteemed President, Dr. Priya Karthik Prabhu, Secretary in absentia Sri Ramalingam, Finance Secretary, for their unwavering support for this wonderful program. We are also immensely grateful to our state AMS chairman, none other than our Professor Dr. Rajesh Babu, very vibrant chairman of our state, and branch AMS chairman Dr. Balamurugan for granting us the opportunity to organize this important need of our virtual CME on All India PG's webinar on neurosciences. A special thanks to all the speakers of the day, Professor Emeritus, Dr. Pazhani Ranganthan, Tamil Nadu MGR University, Regional Advisor, Royal College of Physicians of Edinburgh, for graciously accepting our invitation and delivering insightful presentation, enlightening us about the brain death. That is the brain death in neurologist perspective. Then again, our vibrant, the stalwarts and the speaker, Dr. Ragahavendan, Director and Professor, Institute of Neurosurgery, MMC Chennai, for his deliberation on brain death, neurosurgeon's perspective. Excellent, sir. And for the outstanding deliberation on this important issue, which every physician, those who are handling, starting from the newborn to the elders, this is a very gray area you have highlighted in detail. There are still, we are not able to understand some of the features, sir. So we also thank, sir, for this, both of you, on behalf of IMA AMS Coimbatore. Also thanks the course director, Dr. V. Rajesh Babu, Senior Consultant Neurosurgeon, Ganga Hospital, Coimbatore, and Dr. Vikram Muthu Subramaniam, Senior Consultant Neurosurgeon, Sri Ramakrishna Hospital, Coimbatore, for arranging this meeting. We also extend our gratitude and thanks to the moderator, our chairman, Dr. R. Balamurugan, IMA AMS Wing Kovai, for sparing his time for this medical update. We extend our gratitude to all the IMA members and medical professionals and PG students who took time out of their busy schedules to attend this event, demonstrating their commitment to continuous learning and professional development. Once again, let me thank you all for your unwavering
Thank the East West Pharma also, sir.
participation.
Sir, Jalil sir, the East West Pharma also to help us.
Yeah, I thank the East West Pharma for sponsoring this.
Naveen, yeah.
And Naveen,
Thank you, sir.
special thanks to you, sir, for sponsoring this. And let me thank all our members also. So Jai IMA and Jai Hind. Thank you, sir.
Thank you, sir. Good night, sir. Good night, all. Thank you.
Sir, thank you,
Thank
sir.
you, sir.
Sir, we are
Thank you, sir.
always there for any queries at any point of time.
Thank you,
Any-
sir.
Please, sir.
Thank you, sir.
Thank you, Raghavan. It's good to see you. Good to
Yes,
meet
sir.
you. Huh? Good.
Thank you, sir. Thank you very much.